Hi, it's Jenny B, NSWC. Today I want to talk to you about the infectious disease component that wound care gets kind of involved with when we're dealing with wounds, especially those that are chronic and have been heavily infected. First thing I want to talk about is the two main types of bacteria that we do see within wounds that are actually quite common. Both Staph aureus and Pseudomonas are both bacteria that lay in our skin. Some of these bacteria are actually within our water systems, within our within our daily environments in the soil, and some of them are really good bacteria. The problem is when these become harmful and they're either causing some contamination, or when there's actually infection involved where the host, the body itself, is mounting an infection. So one of the big differences, and if you're a little bit of a nerd like me, I'm going to put these two articles attached into the video so you can read a bit more about them, is between Staph aureus and Pseudomonas. So the Pseudomonas, if you'll see, are rod-like projections, where the Staph aureus are nice and round and they're kind of jumbled together. A lot of people do carry this on them. As I said, it's a normal to lay on your skin. The biggest difference between the two is not just the shape, but also that gram-positive antibiotics are going to treat Staph aureus infections, where gram-negative antibiotics are going to treat a Pseudomonas infection. Pseudomonas differentiates too from Staph aureus because it has a very sweet smell. It's one of those smells that once you've noted it, you'll remember it again because of it. It is very strong, but it's very sweet. It's not foul like some other things can be, especially necrotic tissue. And it again also has a bright neon green discoloration. So not all green means that it's Pseudomonas, but it's that bright neon that you're seeing. It's a yellow turning to that green that really indicates that there may be a Pseudomonas infection. So why is this so important? Well, the problem is, for the majority of it, majority of infections are gram-positive, where we're using a certain types of antibiotics, to treat that type of infection. Often, because the most common are Staph aureus. But when we do have the Pseudomonas infections, they require a completely different type of antibiotic. And again, it sometimes get left out of the mix, and the Pseudomonas then can become chronic if it's not treated. So one of the tenets that we use in wound care to have good antibiotic stewardship is to always do that swab prior to initiating antibiotics. Even if they are in the emergency department, it's something that I do work with our emergency physicians, is that I'm really educating that we want to take a good swab first before they've had any drug in. Because once you start taking that antibiotic, and if we swab it even days later, that antibiotic is masking whatever types of bacteria would potentially be in the wound, so we might not actually be treating the right thing. So again, that's one thing that we always encourage. And again, as nurses, that we would actually ask for or recommend swabs first before we're then asking or recommending antibiotics be ordered. Again, if we can go back to the nerds and stones, if there is erythema or, a couple of the symptoms for infection, we want to make sure that there's at least 3 or 4 of them before we're saying, oh, definitely they do need antibiotics, because just having one alone, like some additional swelling or additional redness, and again, we want that redness to be more than 2 centimeters around the wound, some odor, sometimes there's other causes because there might be debris or necrotic tissue within the wound. We want to ensure that, again, we are treating and providing the right antibiotic for the right types of infections. One of the other pieces I want to note and show you how we actually determine some of this, because again, in chronic care, they don't get the same access to the mic or the minimum inhibitory concentration, which is what we're looking at. This is a guide that we use when we're looking at patients. So what happens is, after we get a swab taken, we'll actually go into their chart, and under the microbiology, we'll actually have different types. So I'm going to look at this one here that shows E. coli. So there's different antibiotics that they're going to show: the S, that are sensitive, I, that they're intermediate, and R, that they're resistant, meaning that the amount of drug that you have to give to actually treat and get rid of the bacteria, it's too much, it's too great of a dose, that then they actually deem that to be resistant. So that's what this other chart does show us. It shows what those maximum amounts, or the mic, or minimum amounts are, the mic, in a numeral value. So then when you're going into the chart, if you can actually look up the mic, we actually have the numbers here. So again, it's one of those things that we do over time. You'll know that what the number is for something like ciprofloxacin being less than 1 and usually being 0.06. The other pattern that we do watch is that if we're actually seeing it build resistance, so from past swabs, if we're seeing that this was very low and then we're seeing the number starting to increase, we know that it's actually building resistance. So sometimes we do try to change the antibiotic based on that we're seeing a resistance pattern that's developing. Also, again, we want to make sure that we're treating the right bacteria. So again, that's why that swab's super important, using that Levine technique, ensuring that it's been cleansed prior and expressing fluid, because that's going to give us the best results so that we're providing the patient with the best antibiotic. For the most part, we are trying to give an oral route if we can first before we do an intravenous route. But in this case, this is E. coli, which again, very similar to Pseudomonas, quite often we're giving Cipro, but we're giving several prescriptions of that ciprofloxacin. So if we're finding that it's not working, even if our mic is showing that it should, sometimes we do step it up to a couple weeks of a different drug. One of the most common would be ceftazidime, because ceftazidime is, for Pseudomonas, it's one of the treatments that, again, a 2-week course can actually really kind of knock that back and put it at bay so that we can actually get some wound healing. So that's really for the Pseudomonas piece. Now, the reason that antibiotic stewardship has also become so grand is because we're finding a lot of charts like this where we're seeing all these R's. So this is something that's developed called methicillin-resistant Staph aureus, so that it's resistant to a lot of the penicillins that we're trying to provide because of this antibiotic overuse. One of the good orals that are finding that we're having less resistance to is 1, tetracycline, and 2, Septra or Bactrim. Because if they're not able or they're not sensitive to those oral antibiotics, they end up on something else called vancomycin, which is it's a larger drug in the case that there's quite a bit of a protocol to put the patient on vancomycin. They have to have a good renal status, and because it can cause damage to the kidneys, it has to be monitored on an ongoing basis. So for the most part, we're trying to reduce that so that we're not having as many MRSAs show up, and again, trying to initiate the oral antibiotic route first. So I will put some of these charts up there so that you can have a look, and again, it's something that you can also help. When we see the results come back, we can direct the physician to, let's have a look at the microbiology and see what antibiotics we're choosing. Most part they are doing this, but sometimes we'll get that information prior and can give them a heads up before they're making choices. So that's my little bit of piece on infectious disease. Hopefully they find that helpful, and just remember, the best wound is a closed one.